name is Norm Volsky, your host, and this is the Digital Health Heavyweights podcast.
Thanks, Norm. It's an honor to be here, and it's been fun to work with you over the years.
And today we are thrilled to be joined by Shawn Gremminger, the president and CEO of the National Alliance, formerly known as the National Alliance of Healthcare Purchase Coalitions. Shawn, welcome to the podcast.
Thanks very much, Norm.
Absolutely. So for all of our viewers and listeners that are not as familiar with Shawn as we are, Shawn was most recently the senior vice president at Reservoir Communication Group, where he led communications and public affairs strategy and execution on a range of relevant issues, including 340B and the drug supply chain, employer-sponsored insurance regulations, and Medicare payment. He has a strong history of healthcare advocacy and public affairs with employers, health plans, hospitals, and consumer organizations. Shawn was previously director of health policy for the Purchaser Group on Health, a member of the National Alliance, where he ran efforts to improve quality and affordability for consumers and healthcare purchasers through federal policy. He has held senior leadership roles at Families USA, America's Essential Hospitals. He began his career as a lobbyist for the Children's Hospital Association, and he achieved his master's in public policy from George Washington University and bachelor's from University of Mary Washington in Fredericksburg, Virginia. Shawn, very excited to have you on the podcast.
Thanks very much, Norm. It's my pleasure to be here.
Absolutely. So, we'll talk a little bit about, the National Alliance. It is the only nonprofit purchaser-aligned organization with a national and regional structure dedicated to driving health and healthcare value across the country. Its member represents private and public sector, nonprofit, union, Taft-Hartley organizations with more than 45 million Americans. So, Shawn, what inspired you, to kind of get into the healthcare field at the beginning of your career?
So actually, it's a great question because it was sort of an accident, frankly. So I studied political science in undergrad, went to a school about an hour south of DC, and spent a lot of time in the DC area. So I kind of thought I wanted to be in politics. I didn't really consider health policy as a major focus. And, the accident sort of came in where right out of college, I worked on a presidential campaign in 2004. Turns out I hated it. I just absolutely hated electoral politics. And was kind of looking around and was like, I don't know, I just need to pay my rent. And I had signed up with a temp agency just to find, a way to sort of make ends meet. And the first available opportunity came up, and it was at what was then called the National Association of Children's Hospitals and Related Institutions. And they needed like an admin. I was like, okay, great. So long as they pay me every 2 weeks and I can make my rent and, maybe go out to dinner every so often, I'm happy. And did that for about 6 months and was still very interested in politics and policy. And they had a kind of junior lobbyist position open up. And based on my background and the fact that I guess I was good at making copies and filing things away, I got hired. So I do have sort of a family background in healthcare. My mom was a hospital-based social worker. My sister actually ended up getting into social work as well. So healthcare has been sort of an interest for me. But really, the fact that I ended up in this field was in some ways just a product of a really fortuitous call on January 2nd, 2005, when they said, why don't you come to the children's hospitals?
All right. Well, I'm glad it all worked out. Just out of curiosity, when you were lobbying, was that at the state level, the federal level?
At the federal level. So I was a registered lobbyist.
Right away.
That's right. I skipped right to DC. I was a registered lobbyist at my first four employers. So for 4 years with the children's hospitals, 9 years at America's Essential Hospitals, where I led their government relations work, and then at Families USA doing consumer advocacy, and then have since kind of stayed in the policy lane, but not necessarily as a sort of direct registered lobbyist. Although I do still spend a decent amount of time talking to folks on Capitol Hill.
How did starting your career as a lobbyist help you achieve what you've achieved, the rest of your career?
Great question. So, there's a lot of different kinds of lobbyists. There's kind of the hired lobbyists. There's what I did, which is sort of in-house lobbying, where you start to become a subject matter expert in a particular field. And,
I'm assuming you didn't have like $100 million budget to just wine and dine top government officials, correct?
Yeah, that's right. Children's hospitals do well, to be sure, but we didn't have a political action committee. I was not, meeting with senior administration officials and members of Congress over drinks all the time. A lot of it was sort of the what they call sort of shoe leather lobbying. I was tromping up to Capitol Hill and talking to other staffers who at the time were about my age, right? I'm in my early 20s, mid 20s. Yeah. What it allowed me to do, because we were focused in a sort of specific area, right? Pediatrics, hospital payments, et cetera, is it allowed me to sort of develop a subject matter expertise. And I realized pretty quickly that while I enjoyed the government relations aspect of it, and I like talking to people and occasionally going to a happy hour, what I really enjoyed was kind of getting deep on policy and learning more about how the system worked. And I sort of have carried that with me. So my sort of area of focus has changed over time. For 13 years, it was really focused on hospitals, hospital reimbursement, particularly in the Medicaid space, given who children's hospitals and the essential hospitals that I worked for, which really is a way of describing safety net, urban safety net institutions.
I was going to ask, what is a non-essential hospital?
That's an interesting question. I think when they decided to do the name change, so when I started, it was the National Association of Public Hospitals. They changed their names to America's Essential Hospitals. And this was an open area of discussion, right? Of like, well, are you suggesting that other hospitals are not essential? And the smart folks who helped come up with the name said, well, it's great. Have people ask that question, because then you can pivot back to, well, here's why our hospitals are essential, right?
Yeah.
And they do serve a really unique and important mission as teaching hospitals, as core safety net hospitals, taking care of patients that are often find a hard time having access elsewhere, level 1 trauma centers, that kind of thing.
Yeah, that's great. How has your history of healthcare advocacy and public affairs with employers, health plans, hospitals, and consumer organizations influenced your view on the healthcare system?
Yeah, that's been one of the ways in which my career has been really exciting. Is I've been able to sort of approach healthcare from a lot of different perspectives, right? Hospitals, then consumers, employers and purchasers. When I was at the Purchaser Business Group on Health, that's where I got to know the National Alliance because we were members. And then for 2 years as a consultant working in the public affairs space, and there we had clients across the board, right? Health plans, pharmaceutical manufacturers, et cetera. So I've gotten to see it from almost every kind of perspective. What it's done is given me, I think, a well-rounded view on what the underlying problems are in the healthcare system. And coming to the National Alliance has given me an opportunity to really focus on dealing with those underlying causes. And what it comes back to for me is fundamental misalignment. And in a lot of ways, a broken market that is keeping healthcare costs extremely high without necessarily delivering high quality and value. And having been able to see that from the context of health plans, from the context of hospitals, from the context of pharmaceutical manufacturers and others, I can kind of see how these pieces fit together or fail to fit together.
So as SVP of Reservoir Communications Group, you led public affairs strategy and execution on the 340B and the drug supply chain, employer-sponsored insurance regulations, and Medicare payment. What were your biggest learnings over at the Reservoir Communications Group?
Yeah, I think a couple of big things. So I said I had multiple clients, again, working across different spaces. I think the biggest area of learning was really understanding how these various different constituencies think about healthcare. Obviously, the goal of any company or in healthcare is to serve patients and make money by doing it, right? Yep. And regardless of what people might say about nonprofit hospitals, they are very focused on making money while serving the people they're trying to serve. Yep. From the perspective of, for instance, drug manufacturers, the way they tend to look at it is, we've got these great products. Why can't we get people to buy more of them, right? Yeah. And they often fail to understand the perspective of employers and purchasers, and sometimes fail to understand the perspective of patients. Similarly, on the health plan side, they say, we're providing these comprehensive benefits packages, and we're doing all of this kind of patient navigation stuff, and yet people still hate us, right? We know that the insurance market or the large insurers are not terribly popular. And what I think sometimes is they fail to understand the experience of a consumer who has been denied care, or they fail to understand the experience of a purchaser who said, I don't understand, my cost just went up by 10% last year. Why didn't you help me? So it's a recognition that, people can be expert in their space and still not be able to sort of see outside their box. And that's something that I'm trying to bring into the National Alliance, is to say, as we approach other actors in the healthcare space, let's start with understanding what their perspective is, and then figure out how best to work with them, or in some ways, if we need to, fight them, but at least understand what's going on in their heads.
And what was your greatest successes at Reservoir that you're most proud of?
So, I had the opportunity to work with a client on the 340B drug discount program, which is one area that I know really well because it was a core area of focus when I was at the children's hospitals and then at the essential hospitals. And this client was interested in seeing, is there a way to broaden the perspective of how we view 340B? So it isn't just a sort of fight between pharmaceutical manufacturers and hospitals. And I felt very good about the work that we did. I think we started to sort of create a narrative that's broader and has a better understanding of what the program is, what its problems are, and why others should be interested. And luckily, I've been able to sort of take some of those findings into the National Alliance, where we are now doing a lot more work in 340B and helping employers and policymakers understand why employers and consumers should care about 340B, because it is substantially increasing prices for drugs and other healthcare services in a way that most people haven't really thought of. They've just seen it as like big fight, big hospitals versus big pharma, and everybody else is just watching from the sidelines. I think we've been successful at sort of getting people off the sidelines to say, no, this is something that we should all care about. It's $50+ billion in healthcare spending, and it's not being allocated well.
How do you think your background in public affairs has set the stage for you now to lead the Alliance nationally?
Yeah, what I'm finding, wearing a CEO hat has a lot of, there's a lot of different hats or different jobs within that context, but probably the most important one, or at least, of the top two, the first one is taking care of my members, making sure they're happy and getting their needs met. But number two really is as a communicator and spending some time, again, working as a lobbyist. There's obviously a communications aspect to it, but certainly working directly for a public affairs consultancy has helped me really, I think, fine tune and hone the way in which I talk about the work that our coalitions do and the work that employers and purchasers do. Mm-hmm. It's amazing to me how few people, in DC, in state capitals, and even just in the broader healthcare ecosystem, really understand the perspective of employers and purchasers, our challenges, what we're trying to accomplish. And I see that as being, in a lot of ways, my most, significant job is trying to get that word out there so that, when employers are in conversations with health plans, in conversations with hospitals, physician practices, et cetera, they're not just seeing this as oppositional, but saying, oh, okay, I understand your biggest challenge is prices, and you don't have access to data to understand why you're paying so much, and you're being held to a new to an enhanced fiduciary responsibility requirement, and that's clearly causing you stress. I want that understanding to be more broadly disseminated in our ecosystem, and I think the training in public affairs has been very helpful in helping me get better at doing that.
So I would imagine a common ask by the members is like, we want to pay less and get better quality healthcare. Outside of the obvious, like, what are other things that you and your team do to bring them great value?
Yeah. So you're right. I mean, that's sort of the that's the holy grail, right? Is can we pay less and get better quality? And I think the answer is actually we can, but it's not easy. Yeah, the other things that our core members are regional employer purchaser coalitions around the country, right? And they then represent employers in their space, everything from jumbo Fortune 500 companies all the way down to, employers that may only have a couple dozen people. So their needs vary significantly. The thing that I'm finding that we do is, and have to continue to grow into, is helping them serve their members in a better way. Our coalitions range in size from being quite large to relatively small. We've got some coalitions where they might only have a dozen, 24 member companies and 1 or 2 staff. And, they have to consistently deliver value to their employers, right? They have to consistently be bringing new ideas, new products or services to bear. And the National Alliance, is a big part of that role, right? Because we have sort of a national perspective. We have the resources to be able to produce, whether it's thought pieces, roundtable discussions, tools, et cetera, and making sure that we're getting those in the hands of these coalitions so that they can then deliver them to their employers, and making sure that they are actually structured in a way that is going to be resonant with their members.
Understood. How do you see employers and healthcare purchasers sitting at the intersection of the most important issues facing, the healthcare system in the U.S.?
Yeah, so it's funny when you look at most of the ink that is spilled, sort of talking about healthcare and certainly health policy, a very heavy focus on Medicare, obviously. Yep. decent amount of focus on Medicaid, a lot of focus on the individual market, kind of where the Affordable Care Act focuses a lot of its energy. And people often don't realize or forget that actually employer-sponsored insurance still covers a majority of people in the United States. And self-funded employer-sponsored insurance, so the ERISA market that we spend most of our time in, covers over 100 million people, 110 million people. So again, when we think about what are the biggest challenges in healthcare, out of control prices, lack of access, poor quality, the people who are actually paying for that are not taxpayers, at least not directly. It's employers and purchasers. So, and when we say purchasers, by the way, we mean people who are purchasing healthcare. They're not necessarily an employer. They're like a union or a Taft-Hartley plan, but they are acting in the same way that an employer would. And of course, individual families, right? And one of the things that people don't always think about is that even when the employer is paying for healthcare on behalf of their employee or their family, at some point that's actually all employee dollars, right?
Yeah.
Every dollar that we spend on, paying for your premium for your health insurance plan is a dollar that you're not getting in your pocket. So trying to educate the rest of the world to say, when prices go up, you think that United Healthcare is paying more or Blue Cross Blue Shield is paying more. But actually for 110 million people, the largest single group out there in the country, United Healthcare and Cigna aren't paying anything, right? Their job is literally just to administer the claim. It is your local mom and pop shop or maybe your larger business and individual families that are actually paying for all of those.
Yeah.
So we see employers as being, at the center of it, because we're the ones paying the bills and we're the ones who are trying and frankly too often failing to achieve the ends that we've been focused on, which is, as you said, lower costs, better access, better quality. Nobody else is going to make these changes, right? Health plans have no particular incentive to reduce costs. Hospitals, providers, drug makers, etc., all of their incentives are toward higher costs. They want to make more money. The only people who actually can hold them accountable are us. And we have to take that on and recognize that's our responsibility and be working much harder than we have been and much smarter than we have been to achieve that.
I don't want to oversimplify things, but I also want to, cater to our listeners and viewers that might not be focused on this area of the market, like day in and day out. Is the general idea of your coalition and the alliance is to give employers collectively as much negotiating power as some of the bigger health plans out there?
Yeah, I think that's right, or very close to right. The way that I've been talking about it is the role of the National Alliance and our coalitions, which we're working in regions around the country, is to give employers the tools, resources, transparent information, and courage to make substantive changes that are going to bring down costs and improve quality. And all too often we find that we don't have those things, right? So that's our role, right? We're trying to catalyze a change that only employers can make. And just thinking about it briefly for a minute, the way it works in our space is, we hire a third-party administrator, or what sometimes is called an ASO, Administrative Services Only contract, with one of the insurers to manage our claims. And then they go out and they put together the networks and they hire they put the hospitals and the ambulatory surgical centers and the doctors and everybody in their network, and then they sort of are administering our. What we're finding is that those big companies aren't doing a great job, right? So we need to be holding those big companies more accountable. The other thing that employers are doing, and this kind of gets into, I think where some of your listeners may be, is sort of point solutions, digital health tools, et cetera, to try to either bolster a benefits package that isn't always there because of, their health plan's not doing what they want, to sort of fill gaps or to kind of layer on top. And part of our goal is to help employers think about, are those tools the right ones? Are you contracting with the right people? Are you writing the right contracts so that you're holding them accountable? Because if you're going to spend a couple $1 million or $10 or $20 million on a new navigation tool or a new tool to help people with wellness or manage diabetes or any number of those things, you want to make sure that you're not just throwing money down the drain. Yeah. And our experience so far has been there's a lot of money being flown down a drain and without really seeing the outcomes that we need. And we see it as our role to help give the employers the education they need so that they can do the right purchasing and be prudent purchasers of the dollars that they have in their pocket.
You mentioned a couple of areas in which employers have invested money and they've not gotten the return on investment they were hoping for. Are there any areas of healthcare that you are particularly excited about in today's climate?
I think an area that this is probably an obvious one is telehealth. Okay. I think it could go one of two directions, right? We know one direction it's going to go, which is it's going to continue to grow. And that's all good. No problem with that. The question for me is, will telehealth be used as a tool to create more efficiencies and bring down costs while improving patient experience? They don't have to leave their house or their office or whatever to access care. Or will it be just another sort of revenue growth opportunity? And I don't know the answer to that yet. I think it depends a lot on sort of the relative market competition within that space and what the people on the side of how can we make more money on this, how successful they are. And I'll give you an example of sort of this playing out badly. So there's been a long-term, maybe for the last 10 years or so, debate in Medicare around whether we should pay hospital-based practices more than we would pay private practice for the same service, right? And then the idea of equalizing it is called site neutral payment, right? Medicare is neutral as to whether it's being delivered in a hospital setting, outpatient setting, or in a physician practice. We support site neutral payment. We think that consumer or that employers should be paying on a site neutral basis. One of the things we started to see coming out of the pandemic is that hospitals were taking significant advantage of telehealth. They were delivering more care through telehealth services rather than on location. No problem with that, so long as the quality is good, like that's all good. But they were still adding on facility fees to their telehealth appointments, which just boggles the mind, right?
It does.
The idea of a facility fee as well.
The hospitals would be ballsy enough to try.
They are sort of ballsy enough to try a lot of things. And I think in some ways that overreach was actually very helpful in raising the profile of this issue to the point that actually I think we have a reasonable chance of getting site neutral payments done at the end of this year. And in part, it was because nobody on face could defend facility fees for telehealth services.
Yeah, they got caught, and now they got to pay the piper.
Yeah, that's exactly right. So I think telehealth is an area of I think obvious growth and potentially could get us into a direction of higher value. Similarly, or maybe just in a very specific way within that space, telebehavioral health or sort of mental health is delivered through telehealth. I think holds really, really strong promise. There are certain aspects that probably telehealth is not appropriate for. I think people kind of get that. Mm-hmm. The data seem to suggest that mental behavioral health can actually be delivered through telehealth pretty effectively, maybe at lower prices. And the one thing that it can do, which I think is really exciting, is help connect particular patients with particular needs with the right set of providers. So particularly in a mental health space, right? You want to be working with a psychologist or a therapist that you're comfortable with, where you have, a connection and you're actually able to make progress. And for a lot of folks, that might mean, if you are LGBTQ, you might want a provider who is LGBTQ or at least LGBTQ. If you are primarily Spanish speaking, you might want a provider who's primarily Spanish speaking or any other language. Somebody who shares your race and ethnicity. Well, if you're living in a small rural area, the odds of you finding a therapist who kind of meets those needs is pretty low, even in a decent sized area, if you're not living in one of the big major metro areas. But put that into telehealth, and now you have, potentially, if you do it right, you've got access to all the therapists out there that are interested in doing telehealth. And you could actually, I could be sitting in DC and you could be sitting in Norm, wherever you're sitting. You could be sitting in Cleveland and we could have a therapeutic relationship, right? That's very exciting. And I think that's a promise that I'm really hopeful we can get to a place where mental and behavioral health access is increased substantially because of the new technologies that are available.
That's great. There's a lot of employers that are getting point solution fatigue. You as the CEO of the National Alliance, do you have any fatigue yourself, or is that just an employer thing?
I don't have it as bad as other people do, but I will say I am viewed as I don't know whether this is actually accurate or not, but I am viewed as a pathway for point solutions to get access to employers. And some of that is, we do conferences, we have sponsors and vendors, exhibitors, et cetera. Yeah. And that's all good. Like, I think, getting those folks sort of a time to interact with employers is good. But I do spend a lot of time on the phone talking with point solution vendors. And, a lot of them have good pitches. A lot of them, the work that they seem to do seems pretty impressive. I don't have the knowledge base to be able to say, like, this is good, this is not good. Although this is something that actually we're looking at the National Alliance is to see, is there an opportunity for us to weigh in on that? But yes, it can feel really overwhelming. I went to the Vive conference in LA back in the spring, and it is overwhelming how many people are in that space. I will say, and I said this at Vive, I totally understand why employers have point solution fatigue. It makes a lot of sense. And a lot of times I really think employers probably need to go from having 20 point solutions to having like 3 that actually work. But to me, it is the vibrancy of that market, I think is good because it's potentially disruptive. I think we need significant disruption in what is an obviously broken healthcare system. And it also, I think, is an indictment of the big insurers, right? Mm-hmm. Almost everything those folks are selling are things that theoretically good insurers should be doing. Yes. So the fact that we feel like we have to hire patient navigators is an indication that your BUCA, your big insurer, is not doing it well. The fact that we have to hire somebody to help manage hypertension is the indication that your insurer is not doing that well. And I sort of challenged, when I was at Vive, I sort of challenged the payers or the carriers that were in the room to say, like, learn from the people here and figure out what you need to do your job better. Because the goal of those folks, I think at some level, is to put the insurers out of business. And I'm agnostic as to whether or not that's actually a good or bad thing.
Yeah, and I think a lot of these companies that were originally selling to employers are now trying to go the health plan route to get greater scale. And yeah, that's one way the health plans can do it themselves is outsource it, either white label it or use a third party that does it just better, more efficiently, cheaper than they do.
Yeah, and I think it's not too dissimilar to, what you see in the broader tech sector. Small innovative company invents a thing and gets bought by Facebook. I think the good point solutions out there likely will get bought by, a big carrier. My hope is that if that happens, that actually improves, the experience for patients and brings down costs, as opposed to what we've sometimes seen in tech, and I think we sometimes see in healthcare, which is, you get bought by this behemoth of a company and then you sort of disappear into the Byzantine levels, and the cool things you were doing are no longer so cool and aren't really being used, and we're sort of back to square one.
What is your vision for the National Alliance going forward?
Yeah, so
10 years.
Sure. When I was hired, actually even before I was hired, the board asked me to put together a plan to create a strategic plan. We have executed on that and actually have a new framework that is going to go live, and it will be sort of our guiding process for 2025 through 2027. The core focuses are one of the reasons that we were asked to create a strategic plan is they felt like, we're a small organization. We've been around for several decades now, but we're still small. 8 people, $4 million in revenue. Now you put together all of our coalitions, we're a bigger movement, and obviously you put together all of our employers and families, and it's a lot of people. But that we need to be a little bit more focused on what we do. I think the vision for where we want to take the National Alliance is being sort of the go-to resource for, we want the coalitions to be the go-to resource for employers in their area, that the employers know, if I want to be effective in Cincinnati, I've got to be a member of this business coalition. Same thing in Houston, same thing in New York, right? And that our coalitions are equipped with providing, unbiased, deconflicted solutions and tools that employers can rely on. The biggest challenge I think that employers have right now, probably maybe the two challenges that are interrelated. One is, as you may know, it is surprising how small the benefits departments are at large employers, right? 10,000 person company might have 2 or 3 people doing health benefits. That's it, right? Mm-hmm. And they're probably not healthcare people. They're probably HR people who, this is part of their job. Yeah, which means they are heavily reliant on brokers and consultants. And ultimately, frankly, a lot of times brokers and consultants are providing bad advice, sometimes because they're conflicted and they're getting money from the other side, and sometimes because, they don't really have the best information available to the employers. So when you're that reliant on, external parties, you need to have sort of people on your side who are actually providing you with information that you can trust. And that is in your best interest. You may or may not choose to take that advice. That's a different thing. That's where I think we want to place the National Alliance and our coalitions, not to block out the brokers and consultants. They still will have a role, and they still can do things that your average coalition isn't going to be able to do, but that we are providing the kind of, insights and tools that they can say, yeah, I feel more confident that I can be a prudent fiduciary. I feel more confident when I'm writing my RFI with a health plan, and when I'm signing a contract with a health plan, that it doesn't include terrible contracting provisions that put me at a disadvantage. That's where I think we want to be. And hopefully, we actually put this in our strategic plan. We put sort of our vision of what success looks like in 3 years. And they're pretty ambitious. In one place we said, after 3 years, we want the people who are actively involved in our movement to feel more confident about their fiduciary responsibility as a plan sponsor. Mm-hmm. We'll be able to measure that, through a survey. And this is probably the most difficult one. But I was like, let's get this a shot. I want to be able to measure cost trend for people in our network versus people outside of our network. So measuring cost trend for people outside is easy. We'll just look at Kaiser. Yeah. But I want to identify the employers that have been actively involved in the work that we're doing. And 3 years from now, I hope that if they've done the things that we recommend and that we've been able to support them, they should be able to say, nationwide cost trend was 5.5% to 8%, whatever it was, or whatever it will be. And we are substantively below that. If we've done that, I feel like we've had success.
Yeah. Well, I think very, very good chance of bending the cost curve. You did mention situations in which you think the brokers and consultants have misaligned incentives with their clients because of, kickbacks or, financial incentives kind of pulling them in the other direction. If I had to boil it down of like what the biggest issue is, with the US healthcare system, it's just misaligned incentives for everyone that's involved. What do you think are the most troubling misaligned incentives that you think are causing the most strain on the industry?
A couple of things. So I tend to agree with you, although I've got a slightly different perspective on misaligned incentives as an issue. So I'd say from our perspective, I look at kind of where the cost trends are. You've got employers. Their focus should be, how do we provide adequate access, with quality and equity while keeping our costs down, right? So we have a strong incentive to keep our costs down. The next people over from us, brokers and consultants, their financial incentive is to make as much money as they can. And if they can make money by, getting kickbacks from health plans or point solutions or others, they will do that if nobody's holding them accountable, right? So that means they're not providing great advice. So there's misaligned incentive one. The next people down the line are, the TPAs, the big insurance companies. Their incentive is also to make as much money as they can. And you don't make money, at least in our current system, by saving us money, right? Mm-hmm. If you're subject to an MLR, you make the more you spend, the more money you make, right? Because you can take your 15%. And if you're an ASO contract like we have for in ERISA, you don't have an MLR. But in the end, if the health plans, if the employers aren't sort of holding you accountable for lower costs, you don't have any particular incentive to drive toward lower costs. You're better off just continuing to provide a big, broad network and, doing your thing. So they don't have aligned incentives. And then, of course, you get to the providers, and of course, their goal is to make as much money as they can, including for nonprofit hospitals, which very rarely actually operate in a nonprofit space. I like to actually not call them nonprofits. I call them just tax exempt institutions. Mm-hmm. Most companies have to pay taxes. They don't, but they act the same way. So down the line, everybody, that is sort of our theoretical partners, the people that we're working with, their goal is to make money. Our goal is to spend less. In some ways, I think that focusing on misaligned incentives isn't the best way to think about it. They are misaligned. I think of it as just being a broken market. So the way that I've sort of, in my own mind, and you can disagree with me on this one because I think I'm in the outlier here. Think about a consumer buying a car, right? The car salesman's job is to sell that car for as much money as he or she can. The customer's job is to buy that car for as little money as they can. Yep. Their incentives are misaligned. But there is a functional market, right? If the price is too high, I can go out and buy a different car, or I can buy the exact same car at a different dealership, right? Yep. I can engage in a negotiating process that puts me at a better advantage if I'm willing to drive a hard bargain. In the U.S. healthcare system, that market doesn't exist, or at least it's largely broken, right? Because employers have to choose between a small number of health plans. So already you don't have the market that you want. They have to work with those health plans who have a significant information asymmetry. We don't have the data that we need to know whether or not we're getting good value. And, when you go sort of one step further, looking at the hospitals and health systems in most major metro areas in the country, and almost every smaller area, you have either a monopoly or an oligopoly in which, hospitals can basically set prices. And we have very little ability to actually negotiate lower prices. So the problem isn't necessarily that their incentives are misaligned with ours. The problem is that we don't have a functional market, and the buyers are consistently at a disadvantage to the sellers. And so long as that continues to be the case, we're going to continue to see the same outcomes we've been getting.
Talk to me about greatest learnings you've had at the Alliance and also greatest successes.
Well, I'm early on. So greatest successes, surviving the first year will be a big success. I think getting through our strategic planning process, which again, we're in the process of wrapping up, I think will be a significant success. This is really putting us on a path toward kind of a new idea of what we're supposed to be doing and trying to be really focused on end results and outcomes. Come back and interview me in a year and we'll see. I'll give you a better assessment of like, how far are we along
do a follow-up episode in the future for sure.
Be great. Greatest learnings, I think, is a renewed recognition that there's a perception out there that employers and purchasers are just sort of mindless rubes that just sort of take whatever is given to them. And I think that is, if you went back 10 or 20 years, that's probably not too inaccurate. That's being overly critical of people that I work with sometimes. But I do think too often employers have just sort of taken what they've been given and sort of said, all right, here's my checkbook. I have seen a lot of, and maybe it's because it's a self-selecting group of employers that are involved with our coalitions, but I've seen a lot of energy and a lot of focus on the critical issues that we're talking about. I think particularly the renewed focus and heightened focus on fiduciary responsibility of plan sponsors has created a lot of agitation that I think is going to lead to really good action. You know, when employers see themselves, or at least see the possibility that they will be on the other side of a lawsuit against them, saying you haven't been spending your plan dollars wisely, that really focuses the mind and gets employers to say, like, okay, I've got to take this much more seriously, and I've got to take it up a notch within my hierarchy so that the general counsel and the CFO and even the CEO understand we can't just keep doing what we've been doing. I feel like there's a lot of energy in our space, and I'm excited about, you know, how that's going to play out over the next couple of years.
What are some initiatives going on at the National Alliance that you and your team are just very hyper-focused on?
Yeah. I'll give you a couple of examples. So on the policy side, you know, my background is in policy. We do a lot more than just policy, although it's very much interlinked with kind of the operational work that we do. On the policy side, we are very focused in two key areas: PBM accountability and hospital price. So on the PBM space, we have been working on legislation at the federal level, which would demand much more price transparency for PBMs, ban spread pricing, mandate full rebate pass-through. And again, the transparency is critical to achieving those other two things, right? We can never know without any real transparency whether or not we're actually getting all of our rebates, right? Yep. PBMs may say, oh yeah, you got 90% of it this time or 95% of it this time, but you have no ability to actually audit that and know whether they're lying or whether they're telling the truth. That's a huge area of focus. I think we are closer than we've ever been to getting it done. No guarantee it gets done this year, but we're doing our best. On the hospital side, you know, we've been supporting legislation that would substantially increase price transparency. We've been supporting legislation that probably won't get across the finish line this year, which will ban certain anti-competitive practices by hospitals that we know drive up prices. And one area that I think at least have a chance on is the ability of plan sponsors to have audit rights for their own data. And this is a big kind of underlying problem we have. And we talk about the information asymmetry, is getting data out of our TPAs, out of our contracts with others. It's very hard to know where your spend is going and why it's going that way. Often the information we get is so high level that it's not really actionable. So legislation that would really insist that we own that data and then we have the ability to audit it and we have the ability to act on it. That's another significant area of focus in policy. I'd just say on the non-policy side, we're doing a lot of different things. One that I'm excited about, I actually was previously sort of a skeptic of it, and I've been turned around on it, is a focus on helping employers with their very high cost claims. So we know that, you know, the top 2 or 3% of claims drive 40 to 70% of cost, depending on the employer. A lot of those high cost claims are unavoidable. You know, you get hit by a bus, you get cancer, it's not going to be cheap. But what we find is that we know there's an enormous amount of waste in healthcare, and a lot of that waste is in those 2 or 3%. And we've been doing work with a consultant and working with our coalitions and employers to help them better understand their high cost claims and look for opportunities where you could literally just move the site of service.
What is a high cost claim that could be avoided or charged much less, but it gets inflated unnecessarily?
Yeah, sure. A couple of big things that we can do, right? Usually you can't avoid it, but what you can do is you can mitigate it substantially in a lot of cases. So site of care is a big one. If you have a person who is on a very high cost infusion, right? Some sort of maybe cellular gene therapy or some other kind of high cost infusion. If they're getting that infusion at a hospital-based center, you might be paying $500,000. You could potentially move that person to a non-hospital based outpatient center, and the price of that drug is $200,000.
Yep.
Same drug, same quality, same experience, maybe even better experience, and you've saved $300,000 without in any way impacting or negatively impacting the access to care or the experience of the patient. So site of care is a huge area. Another is actually putting into place, it is issues around step therapy and medication management are often controversial, but it is remarkable as we've had our folks look through their data, how often you might have a person on a very expensive therapy where they didn't receive a biomarker or genetic testing at the front end to confirm whether or not they actually even need that thing. And I'll give you sort of one story very quickly of of course I have no idea who this person was, certainly personal health information. But I got this through one of our employers. A pediatric patient who was on a very expensive therapy. It cost $1 million a year. They had been on it for 2 years. They weren't seeing progress. And our folks looked back through the medical claim and said, gosh, there's a genetic test that can determine whether or not this person has that disease, right? It's not always that simple. Sometimes it's much more complicated. But in this one, it was like, do the test. It's either yes, you have it, no, you don't have it. No idea why on earth a physician would prescribe somebody to be on a drug that costs $1 million a year without doing this test. And absolutely shame on the PBM for not bothering to check. But of course, the PBM was probably making money on the deal, so they were happy to dispense it. The employer stepped in and said, I need this person to do the $5,000 genetic test. Guess what? Kid didn't have that disease. The plan had spent $2 million. The kid wasn't getting better, probably having significant side effects, and could have been solved if somebody had actually bothered to do the right process.
Yeah.
It's a shame that employers have to be that backstop, but it's another example of the way that you can look at your 2 or 3% and find so many errors and so many opportunities for savings just by diving deep on particular disease states or particular patients.
So you site of care because in the vendor world, we've definitely seen some vendor fatigue in the last couple of years. We've seen for a lot of point solution vendors, they've had underwhelming years commercially because I don't think many benefits managers are buying a whole lot of things that don't save money right away. But site of care is actually an area where there's a lot of traction. I would argue the hottest area of the market right now are direct contracting companies that are COE companies that kind of create their own networks outside of the traditional health plans and are always focused on very high cost dollar figure items. What do you think about those companies, in terms of innovation?
I'm a huge fan, and not of any particular vendor, although I've talked to a lot of them and I think they're doing good work. To the extent that we can disintermediate employers from providers, i.e. get the plans out of the way, I think we're better off, right? Yeah. Because you lose so much of that overhead, you lose so much of that misaligned incentives that we might have for the health plans. I've been seeing places that are doing, I think it's direct, I'm going to mention the name of a vendor, Employer Direct Health, which I think is changing their name to Lantern if they haven't already.
Yeah, Carum does.
Yeah, Carum as well.
Work, I think great work.
Yeah. And again, not endorsing one or the other and any of the other people in the space. I think in some cases they're doing direct contracts with centers of excellence. I think it's really smart. We know that centers of excellence, if they are actually going to provide higher quality care, if you have somebody who's done, it's like in a surgical setting, you don't want a surgeon who does this thing every couple of months. You want the surgeon who's done this thing 10 times in the last week, right? So getting people, doing direct contract, getting people out of the most expensive side of care into cheaper sites of care where the quality is still there, I think is a huge movement for employers. And I absolutely think that people who sort of identified this as a solution or that they want to try to invest in, I think that's a really smart place to go. As you said, most employers these days, I think that the days of I'll try anything out for a while, that's over, right? I think employers are tired of it and they're not interested in investing in things that don't have some sort of cost effectiveness and ROI in the shortish term. Maybe not first year, but by the second year, if you're not showing an ROI, you're getting dumped.
But
and there are certain things that
they save dollars day one, week one, month one.
Yeah, which is amazing. And I think it's a really smart place for investors to be looking at.
Yeah, and I've noticed there are companies that are now doing it in other markets. I think the Carums and Lanterns of the world kind of saw what Progeny and Carrot and Win and Kindbody did in the fertility market. And then they did, what they are doing now in surgery and oncology and some other areas. I'm starting to see infusion as being a next direct contracting frontier. Starting to work with some companies who do that. couple weeks ago, we had Elon Adler on the podcast, who's leading One Imaging. They're doing it for radiology services. So I think that is like a really, really great model to get some significant cost savings, in this interim period where there are misaligned incentives, between brokers, between health plans. But if you can directly contract between the employers and the health systems, you're going to be able to, kind of thread the needle a little bit, at least on the big stuff, until we see more healthcare reform. I do have to ask, like, you've been in policy for a couple of decades now. There's always the debate, like, is public healthcare better or is private healthcare better? Do you see a scenario in which in the next half century that the United States could go and just create like a one-payer system? Or do you think like we're way too far down the path to like go back and course correct?
It's a good question. And I will say, actually, I think it is under the current trajectory we're on. I think it's virtually an inevitability. And, I will not express an opinion on whether single payer would be better or worse for the U.S. healthcare system. I think there are strong arguments in both favors or in both sides. Here's the way that I see it playing out. And I actually said this at a National Alliance conference about 2 years ago, maybe 3 years ago, before I was in this job. If we're looking at 7% year over year healthcare inflation, at some point this breaks, right? Like, I don't know when it's going to be. I kept thinking it was going to happen, but at some point it really actually will break. Employers are now paying over $25,000 a year for family coverage. Is it 30? Is it 50? I don't know what it is, but at some point it stops working. And I think what happens at that point is employers pull back and they say, forget it, I'm done. I can't do this anymore, right? And we know that actually employer-sponsored insurance was sort of an accident of price controls in World War II. And I think it depends on who's in charge in DC and states as to what happens next. I think if sort of the more conservative Republicans are in charge, what they will try to do is something that I think probably also won't work, which is, this very sort of free market idea of we're going to sort of give everybody a voucher, a refundable or a advanced refundable tax rebate, whatever, for $10,000, go out and buy your healthcare. Like, that'll work for some people, but it won't work for sick people. And pretty quickly, I think that
plan for
there are. There's ICRAs and I just don't think it works in the long run. I don't think it works for most patients. I think most people won't accept it. In which case, I think we end up at single payer after that. Or, if Democrats are in charge, I think we just go straight to single payer when the employer-sponsored market falls apart. So this is a case that I've tried to make when I've been speaking to manufacturers, hospitals, health plans, who I sort of hold responsible for the price increases that we're seeing, to say, like, guys, your worst case scenario is single payer, right? I got to imagine your worst case scenario is single payer. And yet every year you do things that get us closer to that, because this trough that you're feeding out of doesn't last forever. And I don't know when that breaking point is, but if we don't actually figure out how to get costs into, under control, that's what happens. And I'm 100% sure of this only because I think it's just math. I don't know what the breaking point is, but if employers are paying $50,000 for family coverage, I'm going to tell you employers are going to stop offering coverage.
Yeah, I would agree. Wholeheartedly. I've had like a opinion on this podcast for, almost since its inception over a year ago, that, one of the misaligned incentives in the market is the fact that benefits managers don't have any true incentive to take risks.
Yes.
If they take a risk, if it doesn't work out, they get fired. If they take a risk and it saves their employer $10 million, they might get a Starbucks gift card on their desk at the end of the year. If something works out, like, what's your advice or your idea of how employers can incentivize their benefits leaders to take risks, to try new things?
Yeah, it's a great question. And I actually agree with your assessment. And the benefits leaders are the people that I work for ultimately, right? Through my coalitions, those are
like there's that are doing such incredible things that are not really getting compensated, or like there's just not that many people focused on it, and it's kind of just that like bucket where it's like CFOs like, all right, you handle it, because it's
right. So the short answer to me is it's all about incentives, right? So I would make the benefits leader and a CHRO and a CFO, right? I would say their comp or their performance has to be directly correlated to saving money in healthcare. And, you identify what your goal is, and maybe it's we want a flat this year or no more than 2%, or maybe you say we want to be at least 2% under the national. Frankly, I think the CEO should also be held accountable for this, and say your job is to, without losing quality, access, equity, is to hit this number. And guess what? I think people are going to start getting really focused on this as something they got to do. And until that happens, I think you're right that for most people, the costs of action outweigh the benefits of action.
I think that's very inventive, that get the CFO and CEO's compensation based on this, and all of a sudden, there will actually be forward progress. Well, that's great. We'll leave it at that. Thank you so much, Shawn, for joining us on the Digital Health Heavyweights podcast. And, keep doing the great work at the National Alliance. And we'll have you for a follow-up episode in the next year or two to hear how you and your organization is lowering cost and improving quality.
Thanks very much, Norm. I appreciate it a lot.
Thanks. Thank you for joining. Please like, comment, and subscribe below if you enjoyed it.